An enormous pleasure to welcome you here to the first in a series of talks that are going to look at the potential consequences of any change in the fundamentals of our healthcare system and health safety net, whether that be around the ACA, Medicaid, or Medicare. I just want to flag that before I go ahead and introduce Michelle Doty, who it's an immense joy to have here, that go ahead and mark on your calendars. There'll be another one together with the Center for Health Policy Research, a panel that Jerry Kaminsky will be leading on February 15th. So that's our next date. So it's an enormous pleasure to welcome Michelle McAvoy Doty, who is Vice President of Survey Research and Evaluation for the Commonwealth Fund. She is responsible for designing their studies that benchmark performance in the U.S. And if you haven't seen them, I just highly recommend them. These are truly extraordinary studies that give us great insight into the reality of how does the U.S. measure up to other high-income countries. How good or bad is our patient experience, and how does it compare when you really look without bias? So she leads the fund's organizational performance tracking activities and works with staff to develop measures to assess and track the fund's performance. She's a whole series of publications on high-need patients, high-cost patients, the international health system comparison, nursing homes, healthcare access and quality among vulnerable populations, among others. And among her many accomplishments, I can't help but note that she also has her PhD in public health from the UCLA, now Fielding, probably not then, School of Public Health. So it's just an enormous joy to welcome you back to speak with us on this incredibly important topic about what could happen if the ACA is repealed, recognizing that many of us are going to continue to work for that not to happen. Thank you for being here with us.
Thank you very much. Thank you, Dean, and thank you, Steve Wallace, for helping to organize this. I really appreciate being back here. It's been a long time since I've been here, so this is really a great pleasure. And I welcome your questions, and hopefully I will help you understand better what's happening. You can hear me? How about now? All right, well, maybe I have to speak like this. How's this? Okay, very good. Okay, let's see. It's not advancing. Gotta get it down. Got it. Oops, sorry. There we go. Got it. Okay, in the time we have together, I want to talk about 4 related topics. First, doesn't seem the right arrow. Got it. Okay, first, I want to start with some data on trends in coverage and access to care among Latinos. Next, I want to discuss the current policy environment. And while there's uncertainty about the final outcomes, I will discuss the steps to repealing the ACA and the consequences of repealing. Finally, I'm going to end by discussing what work and research I think will be important going forward, given the current policy environment. At the end of this talk, what I would like you to remember is that, 1, adults, particularly Latinos and Blacks, have experienced significant coverage gains in access and coverage since the Affordable Care Act went into effect. And the consequences of repeal in terms of coverage, economic impact, and job loss are significant. I'm finally going to talk about future directions. Okay, getting this. First, let's start with some national data, which shows trends in insurance coverage from 2010 to 2016 for Latino, Blacks, and white adults ages 18 to 64. Millions of people have gained health insurance through the Affordable Care Act. The uninsured rate for working-age Latinos adults has fallen from 43.2% in 2010 to 24.8% in 2016. Uninsured rates have also fallen significantly for whites and Blacks, but the nearly 20-point decline for Latinos is the largest of any ethnic group. Among Latinos, looking more closely, when you disaggregate Latinos by nativity status, we see that uninsured trends for US-born Latinos, which is the yellow line, are very similar to those of Blacks, which is the green line. But foreign-born Latinos have persistently high uninsured rates, and the main reason foreign-born Latinos who are undocumented are not eligible for coverage through the ACA marketplace, nor the Medicaid expansion. In December, the fund released a report which compared access to affordable health insurance and care across the U.S. between 2013 and 2015, and we used data from CPS and Breakfast. This report showed that many states have made significant progress in a really short time. Uninsured rates for adults ages 19 to 64 declined in all states by at least 3 percentage points, in 48 states and DC, actually. By the end of 2015, more than a third of states had adult uninsured rates below 10%. And despite these gains, uninsured rates remain high in some states, including Florida, Texas, Oklahoma, where at least 1 of 5 adults are still uninsured. States' decisions about Medicaid expansion to low-income adults has had an impact on uninsured rates, particularly among minorities. Among adults living in 30 states in DC that expanded Medicaid at the time of the survey, uninsured rates for Blacks, whites, and US-born Latinos are similar, ranging from 4% to 8%. In contrast, in states that had not expanded their Medicaid program, 16% of Blacks and 18% of US-born Latinos are uninsured, compared with 11% of whites. Uninsured rates among foreign-born Latinos are high regardless of Medicaid expansion status. It's important to note that uninsured rates declined even in those states that did not expand in Medicaid, because insurance marketplaces with subsidies and the market reforms made individual insurance more affordable. Let's not forget that having health insurance has real, tangible benefits for people. For one, since we've been tracking this measure, we find that cost-related access problems are declining. Although the decline is not as dramatic as it is for the uninsured rate, data from the biennial health insurance survey finds that the rates of not filling prescriptions or delaying or foregoing needed care doctor visits has also declined. In 2010, nearly half of Latinos reported they did not get care because of cost, compared to 38% in 2016. And for Latinos born in the United States, the rate is even lower at 34%. The Commonwealth Fund's Affordable Care Act tracking survey found that new coverage gains under the Affordable Care Act is improving people's ability to get care. 3/4 of Blacks and US-born Latinos said that they use their coverage to visit a doctor, hospital, or other healthcare provider, or to pay for prescription drug coverage. 6 of 10 of these respondents said they would not have been able to access and afford this care before they got the ACA insurance. There is also cumulative evidence that expanding health insurance coverage produces real health benefits. Benjamin Summers and colleagues at Harvard found that expanding coverage in Kentucky and Arkansas was associated with greater receipt of outpatient, preventive, and chronic disease care, reduced emergency department use, and improved self-reported health status. The ACA has also provided women with improved access to coverage by ending discriminatory practices such as denying coverage or charging higher premiums based on gender. The quality of coverage has also improved by eliminating lifetime and annual dollar limits on essential health benefits and by requiring coverage of recommended preventive services and maternity care. So, there are documented benefits to the ACA. So let's now turn to discussing the current policy environment and what is at risk. First, I'm going to provide a brief overview of the structure of the ACA, and then I'm going to talk about the tactics that are being used by the administration and the Congress to repeal and replace. Are we ready? Okay. So, first, let's talk about the Affordable Care Act. The drafters of the ACA sought to improve access to non-group health insurance and to make coverage more affordable and protective. To do this, they relied on 3 interlocking sets of policies, which you can think of as a 3-legged stool. So the blue leg of the stool established consumer protections for people who buy coverage on their own, including requiring all insurers to offer a plan to all who apply, bans on charging people more based on health and gender, bans on excluding pre-existing conditions, and an essential health benefit package to ensure adequate coverage. The green leg is the requirement that everyone have insurance or pay a penalty. The red leg is subsidies to make individual market coverage more affordable, like people get in employer plans, and expanded Medicaid eligibility to low-income adults. The point here is that if one of these legs is removed, it destabilizes the individual market and the whole thing collapses. Now I want you to remember these 3-legged tool analogy because I'm going to be coming back to it. Okay, so these pictures do not go together. The one on the left is a picture of my kids waiting to go to school, and it makes me very happy. And then the image on the right does not make me very happy. But I wanted to give you a chance to pause and take a deep breath, because before we start to talk about the next part of this talk. So there's going to be a lot of information. Just focus on the nice, happy picture. So here we go. The overall goal is to repeal the ACA. It was a 2 to 3 year transition and replace it with something sometime in the future. Congress cannot just quickly repeal the entire ACA, but key aspects of the ACA, the legs of the stool, can be dismantled. Here is how: through budget reconciliation, executive orders, and replace legislation. So here are the potential vehicles. Budget reconciliation legislation. This allows for an expedited consideration of certain tax, spending, and debt limit. Budget reconciliation was used in 2010 to help pass the ACA. And this process has already been started. The first step was the budget resolution, which the House and Senate passed January 3rd. This resolution establishes an overall budget plan and sets guidelines for action on spending and revenue. The budget resolution also includes an instruction to the committees with health jurisdiction, which means the House and Energy and Commerce, House Ways and Means, Senate Finance, and Senate Health to report out repeal legislation. There is a January 27th deadline that's not binding for these congressional committees to produce the actual ACA repeal legislation and report it out. So far, there's no consensus Republican replacement plan, which has emerged. But a year ago, Tom Price, the nominee for Secretary of Health and Human Services, had a bill that was introduced, that was passed, and then was vetoed by President Obama. So we can expect to see legislation that looks very similar to that one. I'm not going to go into the details of that plan, but you can look it up. But I would say that some Republican congressional and Democratic congressional members are pushing to postpone this 27th deadline. So we will see what happens on January 27th. So the executive order, which was issued on Sunday, cannot undo the law, but it reaffirms the president's commitment to dismantling the law. So it instructs federal agencies to minimize the financial burden of the ACA. And here are the potential changes. It could stop enforcing the individual mandate, could compel insurers to abandon the market in 2018. It could alter the ACA standardized health insurance coverage benefits. And it could also give states the ability to reassess their Medicaid programs, to reassess what they're going to allow, including contraceptive coverage, etc. So again, going back to the three-legged tool analogy, if you remove consumer protections and the individual mandate, the stool will topple. So let's talk now about the consequences of repealing and dismantling the key aspects of the ACA coverage provisions. I'm focusing now on two specific issues: eliminating the premium subsidies to purchase marketplace subsidies, removing the financing of Medicaid expansion, and removing the individual mandate. These are the priorities in Congress right now. Okay. I don't know if you can see, oh, it's a little, all right. Well, this chart is a very useful graphic from a New York Times reporter and depicts the key takeaways from the CBO report that was released last week. It really talks about the effects on coverage. So before the ACA went into effect, there were 57 million people without insurance. Now there are 26 million. In 1 year, after penalties associated with the individual mandate are removed and some insurers have leave the market, the number of insured is expected to increase to 44 million. 2 years later, after Medicaid expansion and marketplace subsidies are removed, we expect to have 54 million people uninsured. And in 10 years, it will look like the ACA never happened. Now, because we do not know what the replacement plan looks like, we do not know how these estimates are going to change. These estimates are only based on repeal, not replacement. The impact of health reform, repeal, and employment. In December, the Commonwealth Fund released a report by Leighton Koo and colleagues at the Milken Institute School of Public Health in George Washington University. This study found that the repeal of ACA tax credits and Medicaid expansion could lead to the loss of 2.6 million jobs in 2019. Job losses would affect every state, but these 10 would suffer the biggest hits. A third of these lost jobs are in healthcare, but the majority is in other industries, such as construction, real estate, retail trade, and finance, and nearly all are private sector jobs. The cuts in federal funding for health reform will likely cause serious economic distress for states. State and local tax revenues will fall, dropping by $48 billion. State and local governments could be faced with declining revenues, and safety net healthcare providers would see their uncompensated care costs rise sharply as millions of people lose their insurance. According to the Committee for a Responsible Federal Budget, repealing the full ACA would cost $350 billion over 10 years using conventional scoring. According to this report, any changes to the ACA should be designed to reduce, not increase, the unsustainable growth in the federal debt. Savings from repealing parts of the ACA must be large enough not only to finance repeal, but also to pay for whatever replace legislation is put forward. This is not an easy task, and it will likely require policymakers to retain or replace the majority of ACA health insurance and revenue offsets. Repeal and replace should also, of course, be evaluated on many other parameters, including what does it do for coverage, economic growth, and individual premium cost. Finally, repeal and replace should aim to continue to recent slowdown in healthcare costs. This is going to require building upon the parts of the Affordable Care Act that appear to have worked to slow cost growth, learning from the parts that have not, and pursuing new changes that address the areas of health reform that the ACA has not addressed carefully. So to summarize, these are the 4 major consequences of repealing the Affordable Care Act. State budget hits, especially for states that expanded Medicaid, loss of current spending and revenues under the ACA, disruption of individual insurance market and insured financial hits, and the loss of insurance up to $25 million. So there's a lot of uncertainty about what is going to happen in the next few months in terms of policy. So what is not uncertain is that since the ACA went into effect, there have been real benefits to people. More people are insured. People who gain coverage have been able to get the care that they needed and they couldn't have gotten before. There have been health benefits associated with increased coverage. And there are real risks to eroding the gains that have been made in just a few years since the ACA went into effect. It's going to be critical that researchers and policymakers and the media understand what is at stake for consumers. However the message is sent, whether your audience are policymakers or the public, there is a lot to be done here in this space. I don't think this is well understood. What are the real consequences to people? On the policy front, there will likely be traction. There will be very little traction at the federal level. So it is going to be important to focus on states. It will be crucial to track the effects on coverage and access to care at the state level. We know that there's lots of flexibility that happens at the state level. We saw flexibilities in states. There are the 31 states plus the District of Columbia that broaden Medicaid eligibility. 16 are run by GOP governors. Nevada was the first GOP to embrace Medicaid expansion. Kasich in Ohio was also supported expanding Medicaid using a waiver. There are GOP governors who publicly are committed to ending Obamacare, but they're telling their congressional delegations that repealing the healthcare law without an adequate replacement would ravage budgets and swamp hospitals with the uninsured. There is an understanding that repealing without replacement is disruptive. So we think that there's going to be a lot of work to be done on this front to adequately document and track what is happening at the state level. I know I've covered a lot of ground. I want to make sure that I leave time for questions. So let me stop there and take your questions. Thank you.
Okay, so folks, just the way this works, I'm going to take one question from the room, then one from online, and so on and so forth, just to be fair to our online participants. Is there anyone in the room who has a question right now? Over there.
Hi, Michelle.
Hi.
So I heard the governor of Virginia, who's a Democrat, interviewed on last night on F4, and his argument was actually that the states that didn't take the Medicaid expansion might be seriously hurt because, and I doubted this, but because the Trump administration or Trump said that he was interested in, or that it was essential to cover everybody, and that you had therefore states that did take the Medicaid expansion were likely to benefit more than those who didn't. I mean, have you heard, as I say, that sounds like a
I mean,
very likely argument to me, but I wondered what you tried.
it's,
If you could repeat the question.
the question is that the states that did not expand Medicaid have more to lose in the ACA repeal than states that did.
Yeah, because of this mandate to cover everybody.
Well, if we're talking about states like Texas and Florida, where the uninsured rate is so high to begin with, that is true. They have more to lose because the uninsured is actually going to increase there. The market subsidies are no longer going to be in place. So even if you look back at the slide that I showed, that even in the states that didn't expand Medicaid, there was still a drop in insurance coverage because there was still the marketplaces, there were subsidies, people could go, the individual market was improved. Despite what you hear, it actually has improved over time. Yes, for some people, the cost of individual insurance has gotten higher and skyrocketed. That tends to be for the group that did not receive the subsidies, who have income 400% of poverty and above. That was part of the design of, that's part of the ACA marketplace reforms that if Hillary had become president, that was something they were going to be working on and tweaking because people understood that the subsidies were not enough.
So we have a question from online. What are the consequences to opening insurance across the states? How would that affect low-income minorities? Would you repeat that?
What are the consequences of increasing the opportunity to buy insurance across state lines? There's a lot of data already out there about trying to make that work. It hasn't worked so far. There's a reason why states haven't adopted this policy of trying to purchase and create grouping of insurance across state lines. I can point you to that research, but there isn't going to be a lot of traction there. The studies show that they don't take it up, it's too expensive, it doesn't have the intended consequences.
In the room?
Thanks so much again for joining us. Can you tell us what your perspective is on what's known about the different replacement proposals? So Senator Collins, other replacement proposals that are out there and their implications?
So Senator Collins, I think what do we know about the other proposals out there for replacement? The best known one is Tom Price, and that it is classic about removing the individual mandate, removing the tax credits, the subsidies for the marketplace, limiting the Medicaid eligibility and subsidies and removing the financing for that. Those are really the main, all plans, the replacement plans from Republican congressional have the same sort of intent. There's tweaking here and there, but it's not enough. It's very difficult to model what the effects are on coverage and insurance premiums based on the information that's provided on websites or anything like that. So it's unclear.
Okay, we have a question from online. Can you evaluate the interplay between using HSA and losing the individual mandate?
Can you repeat that?
Can you evaluate the interplay between using HSA and health savings account and I don't think it means losing the individual mandate?
I'm not sure.
Clarify?
Yes, he needs to clarify that. Those are two very different concepts. The point of the individual mandate is that healthier people join the pool, right? And so if you remove the individual mandate, it becomes more expensive for the insurers to cover those who actually take up health insurance. So I'm not sure what the interplay with health savings accounts and the individual mandate they're talking about.
Okay, we'll come back to it.
Yeah.
Is there a question in the room? Yeah, back there, please.
Thank you, Michelle, for making something very complicated sort of understandable.
Sort of, I know.
We know that the U.S. is very behind internationally in terms of recognizing that universal health care is a human right. And we hear, as Anne pointed out, that Trump still says, "Oh, don't worry, everyone's going to be insured or covered." This is kind of asking you to read the tea leaves for the future, but do you think that the ACA has helped us get closer to a recognition or a public belief that it is a human right to have access to health care?
That's a has the ACA and the changes in health insurance coverage and access to care and sort of exposed and that more and more health insurance and health insurance is a right and is so it is a right. So do I see that the ACA has it increased this sort of notion and sort of improved our understanding of that? I will say that when we do our international health policy survey in 2016, for the first time ever, when we compared cost-related access problems in the U.S. versus 10 other industrialized countries, it's the first time that declined. And we have never seen that before, and that's what we were hoping to see that. It is still, we're still an outlier when it comes to providing affordable health care coverage and access to care to our population. I think that what you're seeing in public opinion polls is for the first time ever people have actually positive feelings about the Affordable Care Act. I think that you obviously see the confusion between the Affordable Care Act and Obamacare, which is really unfortunate. So, I mean, I think that people are getting a little scared and also are starting to recognize that, in overseas and other countries, this is really not an issue. Now, we are entering a time when the U.S. is looking inward. So, we at the Commonwealth Fund have had a difficult time getting this point across and making our international health policy survey relevant to a U.S. audience. There's only so many times that congressional staffers and congressional leaders want to hear that compared to all other industrialized countries, we lag on so many different measures related to access to care, quality of care, primary care doctors. It really doesn't resonate with our congressional leaders. So I'm not sure to what extent that's going to resonate now.
In his town hall a few weeks ago, Paul Ryan talked about potentially establishing high-risk pools, even though that's been proven to not work. Are there any circumstances in which high-risk pools would be a viable solution?
Are there any circumstances in which high-risk pools have been a viable solution? In my experience, no. It didn't work in New York State, and it did not work in other places that had tried to use high-risk pools. It was an approach that was abandoned pretty quickly.
You mentioned the importance of research and tracking, but you also have competing interests of timeliness, which is important right now, but also comparing states, and those are competing interests from survey and administration perspective. And I don't know what data we have that best meet both needs, right? I know that a lot of surveys administered by the Census Bureau produce federal estimates, national yearly, but state estimates every 3 years.
Yep.
So I know you're signing a lot of NHS, and I don't know if that produces state estimates yearly, but where are you looking for the best data?
Right, so, I mean, where are we looking for more data at the state level? Because the federal surveys, when they publish state data, it's every 3 years. So how are we going to track in a timely manner state coverage and access? So that's a great question. As you know, obviously it's really expensive to collect data at the state level. And so in our scorecards, our state scorecards, we use BRIFIS and we use CPS data, and we only come out with our state scorecard every 2 years. I think to be nimble, I think probably private foundations that have to step up and start funding state level data collections, make it uniform so it's comparable across states. Maybe foundations, like a network of foundations, sort of there has to be maybe collective action around how are we going to track these very important things at the state level. So for right now, there isn't a solution. I mean, just to give you an example, when we do our biennial health insurance survey, which is every 2 years, we oversample in only four states. That's all we can afford to do. You know, there are foundations there that have bigger coffers. And so I think that that's probably going to be something that we're going to be seeing going forward.
Do you think an all-payer claims database would help with the measurements of access to care as well as efficiency and best practice services?
Do I think that all payer claimers database will help with measurements of access and care? Yes, I absolutely do. I think we have had some grantees at the Commonwealth Fund who have looked at that. I will say that it's very complicated to get all payer access to all payer claims. Once you get it, there's some difficulties, but I think that that's absolutely doable.
There's a related question: what would it take to develop the all-payer database?
Yeah. What would it take to develop the all-payer database? It would take a lot of money, and it would take sort of kind of political will also. But I mean, that's a good question.
There was any other question?
So I feel like the atmosphere surrounding this topic is one of helplessness. We're kind of just sitting waiting for the storm to hit. Is there anything in your experience that you found that people can do, or suggestions that you have, that's measures or steps that we can take to have an effective change instead of kind of waiting around and seeing what's going to happen?
So instead of waiting around and waiting to see what happens, is there anything that we can do to be more active and to sort of respond to the potential changes that are coming down the road? I do. I think that right now, really putting a face to what's happening, doing this in a really timely manner. Like now is the time to get information out there and to try to reach an audience that really isn't tapped into this data and that it's really going to affect them the most. So there is a window right now. In the next couple of months, when Congress is sort of debating the repeal legislation, there is a lot of momentum that could be built around sort of what the consumers are going to face, what are individuals going to face. I think that is it's going to take creativity. I know there's somebody in the audience here who's working on a documentary with Latinos about this issue. So I think those types of products and those types of sort of outreach are really important. And I also think that, I mean, there's sort of like lessons to be taken from activism, and I'm sure those lessons can be applied here as well.
Question? Yeah, I wanted to follow up on, maybe it's not so gloomy.
Great.
After all. And I want to thank you for your body of work. I'm the chair of family medicine here. And two things happened. 2 years ago, we started a family medicine residency, 2.5, in an FQHC out in Kern County, which is Bakersfield. which has enormous poverty levels and enormous wealth has collapsed as well. And it was one of 40 programs, I think, in the country that started when funding went right to the health centers, to the hospitals, sort of family medicine residency there. It's doing very well, and over the last weekend, Kevin McCarthy, the #2 person in the House, and that's his history, who's had no interest in the ACA, walked into that clinic. Somehow they got him there. And he said, that's the first positive thing I've ever seen from the ACA. This is very interesting. So somebody's pushing back. I think there may be an opening there. The second thing is, I think you said the 10 red states with Republican governors who expanded. They're going to get enormous pressure. And you only need, I think, 3 more senators to switch over.
Yep.
And you can block more of this. So you have Ohio, which you mentioned. So I would think there's a good opportunity with the Senate. And would that be enough, or could they still defund everything through other actions?
So two points. One, that there are some bright lights, bright horizons, bright spots, and that is what's really happening in delivery system reform, what's happening with FQHCs, with ACOs. I didn't even touch on that. And I think that what's important to note is that all this discussion about budget resolution, budget reconciliation, and executive orders really pertain to the subsidies, everything related to taxes and tax credits and the individual mandates. So all those things, all those positive things that happened in the delivery system of space, FQACs are not, that's something that would have to be repealed and with a vote, majority, 60 votes. So that can't happen. So all those things are no one has any dispute that those things have worked and they've made positive contributions. Now, to the question about there are congressional Republicans who have expanded Medicaid. They're very hesitant to make any changes to Medicaid. I think what they would like to do is have some more flexibility about what kind of constraints they're going to put on to folks who get Medicaid, like a work requirement or reducing the health benefits package. So those are things that are going to be probably tweaked a bit, but I agree there could be. There's certainly some movement to try to postpone all this discussion on January 27th to a later date where more can be discussed. I think the idea is the longer that it can be postponed, the more difficult it will be to actually come up with repeal legislation that people are going to accept.
Okay, we're going to take 2 more because we got to be out of this room for the next class. I've got one from online. The focus of your presentation is Latinos. How might other low-income minorities be impacted similarly or differently by repealing the ACA?
I did say focus on Latinos because that's the area of work that I focus on most. But it is this talk absolutely applies to all low-income minorities and just low-income, because the ACA was designed to expand health insurance coverage to low-income and moderate-income adults. That's what it was supposed to do, and that's what it did. So all those gains that were made in the low-income populations, those are the ones that are at risk of being dismantled.
We got one more question, and I'm going to give it to Steve Wallace because he's my boss.
So let's assume the federal government gets out of the business of healthcare and let states do things. Do you think California and New York might go to single payer?
As you know, do I think that, let's say federal government gets out of doing anything at the federal level for healthcare, and think more decisions are made at the state level, do I think that California and New York will move towards a single payer system? And Steve, I don't know. But we can look at where California and New York have been on this, and the record of how they have expanded Medicaid to populations, and have been have been leaders of expanding coverage to adults. And so, although I mean California just recently removed the petition, right, to cover undocumented immigrants. So, you know, maybe they're waiting to do something bigger. So, I don't know. I hope so.
Okay, we have to end it there, but please feel free to email Michelle or myself. My email's up there if you have further questions. We'll send them there. Thank you so much.
Please join me. Thank you so much again, Michelle. And to those who asked whether there's something we can do, I just want to close on a note that these are really close votes, much closer than anybody anticipated. There is a lot that can be done. It doesn't take swinging many votes to block this process. That's why we're having this series. The next one will be on February 15th. But join us and do think of which representative you